Brain death is a topic that's pretty important to me, and I think stories like Patrick's really vividly illustrate how important it is to our mission altogether. Because brain death is one of the mechanisms by which people become donors. I was really delighted to hear his story, and I wonder if you all went through the same emotional ups and downs that I did while I was listening to it, but definitely something to be grateful for. I wanted to basically focus on three questions today. Number one, what is brain death? Number two, how do we go about diagnosing it? And number three, what's different in the 2023 guidelines, the most recent iteration of the brain death guidelines, compared to older iterations of it? So first, let's start out with that basic definition of brain death. So brain death, or death by neurologic criteria, is the permanent loss of function of the brain as a whole, including the brainstem, resulting in coma, brainstem areflexia, and apnea in the setting of an adequate stimulus. So I really think of this as consisting of five key components: that it's permanent, that it involves the whole brain, and then there's the coma, brainstem areflexia, and apnea part of this, where brainstem areflexia is loss of brainstem reflexes like your pupillary reflexes and so on. And you heard a little bit about this from some of the speakers earlier today, but I think it's worth taking a step back and considering how we got here and where this concept has come from. So thinking back to in the 1960s and earlier than that, or around that time, medical technology advanced to the point where it was easier to provide prolonged support to patients with devastating brain injuries. And so, of course, the Harvard Medical School convened its ad hoc committee that issued the first definition of brain death back in 1968. And then several years later, in 1981, it was the Uniform Declaration of Death Act, or Determination of Death Act, that was developed by the President's Commission on the Study of Ethical Problems, it's a long name, in medicine and biomedical and behavioral research, which was a multidisciplinary group. And what they codified into that act was that an individual who has sustained either one, irreversible cessation of circulatory and respiratory functions, or two, irreversible cessation of all functions of the entire brain, including the brainstem, is dead. And furthermore, a determination of death must be made in accordance with accepted medical standards. So if you think about it, prior to that time, circulatory death is relatively intuitive, and people can generally agree on when someone looks like they're ready to be buried. But all of those technological advances presented a new kind of problem that that Harvard Medical School committee addressed and that presidential committee addressed. So why philosophically would you think that brain death is the same thing as circulatory death? In 2008, another presidential committee on ethics that was convened at the time kind of encapsulated an argument that speaks to that. Why is this the same thing? And that rests on, what is life and what is an organism? And an organism, to be alive, and what distinguishes an organism from an inanimate object is that it does something in the world. It has three distinct properties. It receives stimuli from the world, number one. Two, it acts upon the world to get things that it needs. And three, it's got a drive to act on the world to get the things that it needs. So those are the three qualities that constitute a whole organism. And in the setting of brain death, hopefully I'll convince you all, that's what's lost. And so when you lose that, then you've lost the whole of or you've lost that integrated whole organism. And that's why it constitutes death. And that's why it's philosophically equivalent to circulatory death. So following that, those definitions in that Uniform Determination of Death Act, in 1987, in 2011, we got pediatric brain death guidelines. In 1995 and 2010, we got some adult brain death guidelines. And then by 2020, a worldwide group of experts was convened, and it was called the World Brain Death Project. And their attempt was to try to standardize minimum brain death standards across countries. So that was 2020. And then now, by 2023, the American Academy of Neurology and other multi-professional societies got together and revised the existing guidelines and combined the pediatric and adult guidelines to give us what we've got today, which really builds on those minimum standards set out by the World Brain Death Project. Now, you'll notice that I've written up at the top here, brain death / death by neurologic criteria. Why both names? They're used interchangeably in the guidelines. Brain death is the historical term that we're all familiar with, so they kept that, giving a nod to history. But death by neurologic criteria is another name for it that emphasizes the equivalence of neurologic death to circulatory death. So that's why both of those terms are used. And it's also worth noting that compared to previous iterations of guidelines where irreversible was the word that was used, they use the word permanent throughout these guidelines, which reflects injuries that cause brain dysfunction that will not resume spontaneously and that medical attempts to restore function will not be attempted. I think that's something that Dr. Goodwin had actually brought up a little bit earlier. And remember also, I mentioned that Uniform Determination of Death Act stipulated that a determination of death has to be made in accordance with medical standards, right? Accepted medical standards. And I think that since all of those historical committees issued their guidelines, it really has been the brain death, as we understand it, has been the accepted medical standard. But just to provide further evidence of that, these are all the societies that were involved in issuing the most recent set of guidelines, and they represent neurologists, pediatricians, radiologists, neurosurgeons, neurocritical care intensivists, and intensivists. So this is a broad swath of the medical community. So this is really, these guidelines are what define the accepted medical standard of care and what defines what qualifies as brain death. So the first thing I want to talk about is the prerequisites for testing. So do we have the right situation? Does this all make sense? Or is this a condition that would lead to brain death? This is where we worry about establishing the permanence and also that it involves the whole brain. So the first thing that we do is establish the etiology and permanence. So that's to avoid misdiagnosing brain death in mimics, so intoxications or maybe severe Guillain-Barré syndrome. So the guidelines ask us to establish the presence of a catastrophic permanent injury by an identified mechanism. So if we don't know the mechanism, we shouldn't be testing for brain death. We have to know what happened, and that has to be something that could and would lead to brain death. Most often, that's illustrated in our neuroimaging. So right here, I've got a CAT scan. It's a horizontal slice through the head, and what you can see here, this is someone who had traumatic brain injury, and you can see that there's a skull fracture, and there's the loss of the normal folds of the brain because of diffuse swelling. So that's a situation where, yeah, it makes sense that that's a condition that could and would lead to brain death. One new element of those guidelines is that in patients with a primary posterior fossa injury, so that's patients who might be, have direct brainstem injury because of whatever the brain injury was, you also have to ensure that the neuroimaging shows evidence of catastrophic supratentorial injury. So the rest of the brain has to be involved. It's not just the brainstem, but it's also the rest of the brain. And there have been some meta-analyses of historical cases where more than half of patients who were diagnosed with brain death after a posterior fossa injury actually turned out to be brainstem death only without whole brain death. So it's in all of our interests to be consistent about that definition and to ensure that when you have that posterior fossa injury, that it actually really does affect the whole brain. So that's a new requirement in this iteration of the brain death guidelines. And observation is a new guideline now. There didn't used to be anything very specific about that. So, and the most important change is that we're asked to, for at least 24 hours after hypoxic ischemic injury, and so this is often going to be folks who have had some kind of cardiac arrest in the process of sustaining their brain injury. We should observe them for at least 24 hours before evaluating them for brain death. Otherwise, it's reasonable to observe them just to make sure that whatever you did to try to treat them had a chance to work. So if you're giving them agents for increased ICPs, you would want to give that time to work, at least in theory, before evaluating them. So the next thing is, of course, you remember we're trying to avoid misdiagnosing mimics as brain death. So we need to exclude confounders. And those can be physiologic confounders, or they can be metabolic and toxic confounders. So thinking first about the physiologic confounders, we think about temperature. The older iterations of the guidelines had us ensure that the core temperature was more than 36 degrees Celsius. But now there's this additional criterion that we have to wait at least 24 hours after rewarming to 36 degrees if the core body temperature has been less than 35 degrees. So that waiting period is something that's new. So that would apply, for people who are being cooled because of either accidental hypothermia, or if they were treated with hypothermia for cardiac arrest or refractory intracranial hypertension. And then also blood pressure. Well, yeah, if your blood pressure is too low, you pass out. So you want to make sure that your blood pressures are adequate before you can adequately evaluate someone for brain death. The specific criteria are the systolic blood pressure has to be more than 100, and the MAP, mean arterial pressure, that's the new part of this, has to be more than 75. And that's also particularly applicable because as it starts to come up in ECMO patients, what you get is a MAP. So that's new in this iteration of the guidelines. And then next thing is we have to exclude metabolic or toxic or medication-related confounders. So regarding medications and substances, you don't have to do toxicology tests according to the guidelines, but if you do, those should be negative. They do address blood alcohol level, should be less than 80. And for medications that might be in the mix, you don't have to check levels, but if you are checking levels to help rule out confounders, those should be within accepted ranges and not considered to contribute to the coma. For example, pentobarbital, the level should be less than 5. For many medications, we just don't know, or we don't have readily available levels. And so in those circumstances, we should wait 5 half-lives of that medication before embarking on our declaration of brain death. If you take a look at the division policy, it's actually got links to the AAN guidelines, and those are really helpful because they've got a lot of really good tables that go through all of this stuff. So it has a pretty extensive list of medications and sort of the other factors like age or temperature or organ dysfunction that might affect the half-life and when you might need to wait even longer than that. So I encourage you to take a look. We also have to exclude severe metabolic, acid-base, or endocrine disturbances. And likewise, as with the medication tables, there are some general lab parameters that these guidelines suggest. They recognize that there's the cutoffs for those lab parameters are a little bit arbitrary, and so they're supposed to be just general guidance. And then, of course, we need to exclude that the patient is paralyzed pharmacologically, and we can do that by demonstrating deep tendon reflexes or by train of 4 examination. So that was establishing the scenario, that this is a permanent whole brain kind of problem. And now we can turn to how do we go about, through our examination, establishing the presence of coma and brainstem areflexia. So who can declare brain death? And how many exams do we need? Similar to the last iterations of these guidelines, in adults, you need a minimum of 1 exam and examiner. In kids, you need 2 clinicians who do 2 different exams independently, 12 hours apart. And that actually includes 2 different apnea tests as well. What's newly mentioned in these guidelines is that for adults, you might consider having a second exam just to reduce the chances of a false positive diagnosis. And that's explicitly mentioned as something to think about. APPs, so our nurse practitioners and PAs, that's a new mention in this iteration of the guideline. So if local standards normally allow them to pronounce brain death or evaluate for brain death, these guidelines also permit that.
Clarify the specialty of the exam.
So it's appropriately credentialed physicians. So the guidelines are a little bit agnostic as to what particular specialty it is, but they do specify that whoever it is should be competent and adequately trained in it. And what does that mean? They have to have done supervised exams in a clinical setting or have done special coursework. And I actually wanted to call attention to a resource offered by the Neurocritical Care Society. They offer a brain death determination course, which is available in both English and Spanish. But that's one of the ways that people can gain additional education. I guess with regard to specialties, the only people who shouldn't be involved are people who are also involved in the surgical recovery of organs, and that's to avoid conflicts of interest, of course. Okay, so then we get to the examination components, and this is where we get to kind of the meat of the brain death exam. I've got kind of an illustration graphically of the whole thing on that left side. But the first thing that we do, and remember, we're only embarking on this if the scenario is right, if we've been able to say that, we have evidence of a permanent whole brain kind of injury. And this is where we go through and actually try and prove it. The first thing that we have to demonstrate is coma. What's coma, or how do you demonstrate that? The patient has to be unresponsive to visual, auditory, and tactile stimulation, so all those categories of senses. And you also have to demonstrate absence of motor responses. And so that's actually with pain that's applied in 3 different places, to the head and face, to the trunk, and then to the extremities. So that's much more specific than I think guidelines used to be about where pain needs to be applied and what other kinds of stimulation needs to be exercised there. It's worth noting that one of the confounding things here is sometimes that people can have spinal reflexes. So maybe you've heard of triple flexion, which is a spinally mediated reflex. And it's the same thing that, if you step on a nail and you pull your leg back before you really know what's happened, it's that same spinal reflex that can exist in patients who have suffered brain death. And there's actually a whole variety of movements that have been described. And sometimes it's hard to know for sure, if those come from the brain or spine. The guidelines suggest that if that's the case, you're not sure, and you see some kind of a movement, you can consult with a colleague who's experienced in assessing brain death, or that might be a case where you proceed on to an ancillary test. So then we go through and test for brainstem areflexia, so loss of those brainstem reflexes. And as you're going through all those cranial nerves, they each correspond to different levels of the brainstem. So by going through all of them, you're essentially evaluating the whole length of the brainstem and trying to demonstrate that there's no function. So you get to this if you've already evaluated for coma and there's no response to any of those stimulations. So we test the pupillary light reflex. We're looking for it to respond to light, and in brain death, there shouldn't be any response to light. A lot of you might use pupillometers in your hospitals, and the guidelines, they actually rely on just the straight physical examination of the pupils, and pupillometers are considered an adjunct, but not necessarily the test by themselves. You look for a corneal reflex, touch the cornea and look for a blink. If there's no blink, that's consistent with loss of that reflex and brain death. Then there's the oculocephalic reflex, and that's the doll's eye reflex, where you turn the head like that. And if the brainstem is working, the eyes should stay pointed relatively the same in one direction. So the reasons you wouldn't do that reflex are if you're concerned about cervical spine stability, or there's a basal skull fracture, or you can't actually see the eyes or something like that. But absence of that reflex would be supportive of brain death. Then you go to the oculovestibular reflex, and that's a much more potent stimulus. So that's where we take the cold water and inject it in alternate ears, looking for any movement of the eyes as a response. If the brainstem works, your eyes should deviate in response to having cold water injected into the ear. In brain death, they wouldn't. They would stay still. And then there's the cough and gag reflexes, which we're obligated to test both of those, actually. But those are absent in the setting of brain death. So we have to assess all those elements and then perform an ancillary test if we can't complete all those elements, or if you're just not sure about the spinal versus brain origin of the movements. Okay, so that brings us to kind of that fifth element there, the apnea testing. So when it comes to apnea testing, I think you'll find that the guidelines now in 2023 are quite a bit more stringent than they used to be. The baseline conditions are a little bit different. Your CO2 needs to be normal, 35 to 45, but if you know that they have a chronically elevated baseline, your CO2 should be at that chronically elevated baseline. Or if you don't know, but you think they do, you suspect that they have a chronically elevated baseline, then you try to get the CO2 to that level. Also, your pH has to be normal, 7.35 to 7.45. So the apnea test, the way it's conducted then is that you take a patient, draw an ABG after satisfying these requirements. And then you pre-oxygenate them, of course. So there's your PaO2 has to be greater than 200. So those are the requirements. And you draw an ABG, disconnect them from the ventilator, and then you observe for 8 to 10 minutes for any evidence of an attempt to breathe. This is an example of one way of conducting that. It's where you can see that this mannequin is disconnected from the ventilator, but has a catheter supplying oxygen running through the endotracheal tube and then a PEEP valve connected to it to try to help prevent oxygen desaturation there. So what qualifies as brain death? Well, if they make it that whole 8 to 10 minutes and they satisfy all three of those criteria there, the CO2 has to be greater than 60. It has to be a 20 millimeter rise above where you started from, and the pH has to be less than 7.3. Remember, the old guidelines really just said you had to have a CO2 greater than 60 or a rise of 20 over the baseline. So this is much more stringent. And that's, if you get to a point where you've demonstrated all of those are true and the patient hasn't breathed, then you've satisfied that requirement of saying, okay, now we have apnea in the setting of an adequate stimulus. And I think that they, in this recent iteration of the guidelines, have focused on satisfying all three of these because the medullary chemoreceptors actually are sensitive to both pH and CO2. So hence the more stringent requirements. Okay, and ancillary testing. So why do we do ancillary testing? Brain death is fundamentally a clinical diagnosis. And the only time that you go to do extra tests beyond just the clinical examination is if for some reason you can't do the clinical examination or you can't do the apnea test. So what are some of the reasons why that might be true? Okay, so maybe you might not have been able to correct all of the metabolic derangements adequately. Or, this is a CAT scan from a patient who had a gunshot wound and an avulsion of his eye in that setting. So, you can see that in this plane, that globe is absent from the orbit. And so that's a situation where you can't see the eye, and or it's not hooked up properly, and so you're not going to be able to do those tests, like look for the pupillary or corneal reflexes or vestibulo-ocular reflexes. Inability to interpret movements, like we mentioned, or if you're worried they're too unstable, you can't do the apnea test. That would be another reason. And then this is a new thing. If you think they have chronic hypercarbia, but you don't actually know what the chronic baseline is, in this version of the guidelines, that's actually an indication for doing ancillary testing. Yes?
Would severe spinal cord injury also include, are you able to do brain death testing clinically?
Depending on the level, yeah, if it's a high cervical injury, and they wouldn't be able to breathe even if they had drive, then you couldn't really do an apnea test in that setting. Thanks for bringing that up. And then you would proceed into ancillary testing at that point. So there are contraindications for ancillary testing too, actually. So again, you're only doing ancillary testing if you can't complete all of that physical evaluation, or you can't interpret the findings adequately. But in hypothermia or high levels of CNS depressants, you actually can't use ancillary testing in that setting because it's not clear always how that affects cerebral blood flow. And so that could lead you to false results on your ancillary testing because all your ancillary testing is looking for, is there blood flow to the brain? And also, you shouldn't use ancillary testing just because someone has a skull fracture or a CSF diversion device like an EVD. And so what are our ancillary tests? The acceptable tests here are all ones that center around demonstrating the presence of blood flow. So you can use conventional angiography. And so this is a picture of someone who's getting dye injection into their cervical carotid. And you can faintly see the outline of the skull there. But what's notable here is a demonstration of how the blood doesn't actually enter the brain. So that's consistent with brain death. You can use radionuclide cerebral blood flow scans. So this is someone who's been given a radioactive tracer that's taken up by metabolically active tissues. And what you see there is that there are other tissues that show some uptake because there's metabolically active tissue, but not in the brain. So there's an absence of brain function that's demonstrated by that. Or transcranial Dopplers, where you're looking for reverberating blood flow patterns when you do the bedside ultrasound. Notably, the transcranial Dopplers you can't use in kids. It just hasn't been validated in that population. So interestingly, and those of you who've been at this a while know that in the past, EEG was one of the tests that we could use to help confirm a diagnosis of brain death. That is no longer a recommended test. And that's because, part of the reason that we even bother doing these ancillary tests is often because we can't adequately evaluate the posterior fossa. And it turns out, well, EEGs don't really adequately evaluate that either. So that's kind of fallen out of favor. Auditory evoked potentials, somatosensory evoked potentials, not acceptable tests. And CT angio and MR angio are kind of appealing, but they really are just investigational. They haven't been validated in this. And part of that has to do with, in comparison to this, which is a conventional angiography, which is a direct arterial injection, you have to account for venous injections in those circumstances getting to the arterial phase. And so I don't think that's been very well worked out, which is why they're still investigational right now. Okay, and communication about brain death and death by neurological criteria. I think all of us probably do this, but we ought to make a reasonable attempt to inform families about our intent to evaluate for brain death. But unless it's stipulated by local regulations or policies, there's no obligation to consent before doing brain death evaluation. There are, so most neurologists and intensivists don't believe that you ought to need consent for that kind of evaluation. But there are a couple of states that I think require consent before doing the evaluation, like Montana and California and Kansas, I think are the ones that I've read about. But most states are they don't really speak to that. And then once you've made that declaration, it's reasonable to provide families with a limited amount of time with the deceased patient before actually discontinuing the life support. So two other quick things about communication. In pregnant patients, these guidelines recommend that you have a discussion with a multidisciplinary team present about what the implications are of continuing maternal organ support. And then, a second really important thing is conflict. So more than half of clinicians involved in brain death evaluation report that they've had conflicts with family about either the going about brain death testing or the meaning of brain death. And what these guidelines ask us to do is just, as institutions or hospitals, have some kind of a policy that addresses how those conflicts will be heard and addressed, although it doesn't specifically lay out the policies itself. But conflict is pretty common. So what we've talked about then is, what is brain death? It's that series of 5 criteria that it's a permanent whole brain injury that causes coma, brainstem areflexia, and apnea. We've talked about how do you go about assessing for it. One is that the scenario has to be right with imaging, the exam has to look like that, and the apnea test also has to show brain death. And then we use ancillary testing alongside all of that if we need to. So that's how we go about doing it. And then in the 2023 guidelines, we talked about some of the major differences. And I think some of the major differences that are worth remembering are that there's a waiting period now for hypoxic ischemic injury and hypothermia. The blood pressure criteria are a little stricter. The apnea test criteria are a little stricter than they used to be. And then also EEG doesn't really count anymore as part of our evaluation. So I hope that you've all found this helpful.